Hi everyone, my name is Michael Stewart. I'm with the OI Foundation as the Director of Education. I want to thank you for joining us this morning for the day 2 of the first ever virtual conference with the OI Foundation. Today's session is going to be managing chronic pain and fatigue for children and adults with OI. We're going to get started in just a few minutes. If you're just joining us, you'll notice that your microphone is muted. Please keep it muted throughout the entire session. Also, I wanted to announce that we have closed captioning available for those who want it. If you go to the closed caption button at the bottom, near the bottom of your screen, hopefully this arrow should just about line up with where the closed caption and then show subtitle button is, and that closed captioning will be available throughout the entire session. Also, I wanted to announce that today's session, like all other sessions at the virtual conference, is not meant to be telemedicine for any of our community members or people on the call. What this means is that we ask you that for the questions you're asking, the speakers, the doctors can all answer questions that are broadly about treating OI and related to our topics at hand, but they cannot answer specific medical questions for you. We ask you that you just please be aware of this when you're asking your questions, and we will do our make every precaution to do that when we're answering your questions as well. Like other sessions, we're going to be having a panel of speakers talking and then having one large Q&A at the very end of the session. So if you have questions throughout any point in the talk, you can write them into the chat bar that you'll see below, and we will get to them near the very end. Again, we want to remind everyone, please mute your microphones so that we can best hear the speakers giving their information. We understand, we're all, most likely, most of us are at home or social distancing, and we get that we're not in our normal office environments. We're not all in the same room together, but background noises can be distracting. Doors slam, dogs bark, babies will cry. We just ask that you please mute yourself when you're not directly talking or throughout the entire session. So thank you very much in advance for that. And with that being said, I'm now going to introduce Christine Rossi, who is going to be introducing our speakers.
Thank you, Michael. Good morning, good afternoon, good evening, wherever you're calling from. My name is Christine Rossi, and I am so excited to be here today representing the OI Foundation Board of Directors and to welcome you to the OIF virtual conference on managing chronic pain and fatigue for children and adults with OI. We are honored to be joined today by Dr. Mahim Jain from Kennedy Krieger Institute and Johns Hopkins, Dr. Mark Popenhagen from Phoenix Children's Hospital, Dr. Jessica Goeller from Children's Hospital and Medical Center Omaha, Dr. Christopher Joseph from Kennedy Krieger Institute, and Dr. Daniel Sova from Johns Hopkins. At the OI Foundation, it is our mission to improve the quality of life for individuals with OI through research, education, awareness, and mutual support. And programs such as this virtual conference are a perfect example of the dedication of the OI Foundation and the Medical Advisory Council members to ensure that members of the OI community have access to up-to-date medical information and social sessions, even during a global pandemic. And one might say, especially during a global pandemic. Even more exciting is the fact that we've been able to provide this weekend full of information sessions free of charge to anyone who wants to participate. In these unprecedented times, as the OI Foundation strives to continue providing current information to the OI community, your gift in any amount is greatly appreciated. And on a personal note, I just wanted to share, I started fundraising events 16 years ago when my son was born with OI. And I did it to help make a difference. And the reason I do it year after year for the OI Foundation is because, to me, the OI Foundation is our hope. I can tell you firsthand, there isn't an organization made up of more dedicated, more brilliant, more compassionate, more amazing people at a staff level and with the medical team, many of who you'll hear from today, than this group of people at the OI Foundation. So again, to me, they are our hope for better treatments, better supports, and overall a better future for all of us living with OI. If you are able to, please consider a donation. Any amount is helpful. And you can go to oif.org/donations/virtual conference. And I'm sure we can put it in the feed as well, so you can have that link. And now I'd like to thank you for allowing me to introduce this amazing group of people. And I'd like to turn it over to Dr. Mahim Jain, who will be chairing today's session to get us started. Thank you so much.
Great. Well, good morning, everybody. My name is Mahim Jain. I'm the director of the OI program at Kennedy Krieger Institute. This morning, we have a very important session. And it appears to be a very well-attended session as well. So first off, I just wanted to thank the OI Foundation for setting up an amazing virtual meeting and all of their hard work. Chairing and organizing this session has been very easy with all of their help. So, I also know that we missed the opportunity to meet in person. I'm hopeful that next year we'll be able to meet face to face and hug all of our old friends. So, my role today, I'm going to provide an overview of pain and fatigue in OI. And we have a very experienced panel who will initially share their experiences in the first hour, and then we'll do questions in the second hour. So this slide shows information that we've collected at Kennedy Krieger that shows something that we're all very aware of, that pain is common in OI. I showed this slide yesterday during the adult session. But for the purposes of review, our experience is that pain increases in OI with age. We observe that complaints of daily pain starts for some individuals in childhood. And there's an increase in pain complaints during adolescence and early adulthood. We also observe that about 80% of people with OI will have complaints in their early 30s. This data is for OI type 1 or mild OI, but we see very similar numbers for individuals with the moderate to severe forms. So we know that individuals with OI will often have a slowing down of fractures at the timing of adolescence and young adulthood. But at the same time, we're seeing increased complaints of pain. This shows us what we're already aware of, that there's pain outside of fracture pain in OI. And people with OI are prone to developing pain from other causes, such as osteoarthritis. So in this figure, I'm showing again data from mild OI patients. What we see is that complaints of pain increase with the number of fractures that an individual has. Unfortunately, when I tried to look at individuals with type 3 and type 4, the moderate to severe forms of OI, we were not able to complete a similar analysis. But what this shows is that there is a correlation between fractures and pain. However, this isn't the full story. We see that having greater than 7 fractures relates to having about an 80% chance of having pain. And the proportion remains steady between about 7 and 40 fractures. So within this group of patients, we see that, with greater than 55 lifetime fractures, we see that 100% of our cohort did complain of daily pain. Good. So, just to review, there are numerous types of pain that people with OI may experience. It's not uncommon that when I'm speaking to groups outside of the OI community, and I say people with OI have pain, they say to me, well, of course they do. They have fractures. But, the data I just showed that shows that fractures are just one type of, one cause of pain for individuals with OI. We can also see arthritis pain, muscle pain, and nerve pain. And we often observe a complex pain presentation in adults with OI. This can include pain at multiple sites of multiple types and can include other types of pain, such as chronic headaches or abdominal pain. So evaluation of our patients with OI that have many types of pain, it's not a simple clinic visit. Often it takes a multidisciplinary approach and a long relationship with frequent visits to disentangle all the types of pain and follow that up over time. So, fatigue is also present in OI, and it's very challenging to disentangle underlying causes of fatigue. Some medical causes, such as endocrine issues or anemia, can be evaluated by simple blood tests. Other medical causes, such as sleep apnea, may require a sleep study. But we do know that for individuals in the general population, as well as people with OI, that pain and fatigue can be present together in the same individual. And we often think of the presence of chronic pain as being a risk factor for having chronic fatigue. So I've listed several causes of fatigue that are possible for individuals with OI. Sleep disturbances are often what we think of and can be a clinical target when fatigue is present. We can also evaluate for endocrine or hematological causes. Nutrition is also an important consideration. In my experience, individuals with OI are probably very similar to the general population, in that individuals with OI are prone to skip meals, or go for fast food, or get in a cycle where the diet may not be totally optimal. So one thing to consider is optimizing nutrition. We know that psychiatric diagnoses can be associated with fatigue, and this includes anxiety, PTSD, and or depression. Medication side effects should also be considered. We know that several medicines, including those that we use to treat pain, can lead to drowsiness or fatigue. Physical deconditioning, or doing too much activity compared to one's ability with endurance and strength, can lead to fatigue. Another correlated diagnosis may be dysautonomia, where there's dysfunction in the autonomic nervous system. Feeling dizzy with changes in position may be a clue, and cold and heat intolerance may be another. Individuals with dysautonomia can report having brain fog or slow thinking that can contribute to fatigue. So in this figure, I'm showing a common pattern that we observe clinically. So there may be a medical cause for pain, such as a fracture or a pinched nerve. This can lead to the presence of pain, which limits one's physical activity, leads to physical deconditioning, which can lead to anxiety, and there may be an effect on sleep, which can lead to fatigue, or the starting of pain medicines that can lead to fatigue. The problem is that with the worsening fatigue, and that only leads to less physical activity and potentially the start of new pains, and this can create a vicious cycle. Similarly, there may be contributions to fatigue, such as sleep apnea or anemia, or increased stresses at home or work. With fatigue, we see physical deconditioning and can also see contributions of stress and anxiety. And this can cause the pain to worsen. And this can lead to the cycle happening from the other side of the equation. So this cycle can happen quickly. However, my experience has been more that in adults, it's a little bit of a slower process and can happen over years or decades. So a common story we observe for adults with OI is pains may start in one area, and for this individual, starting in the back. This leads to less physical activity. This leads then to worsening of the pain, and over the course of years to decades, new pains emerge. So for this individual, in spite of trying a number of treatments, such as medicines and even surgery, daily pain and fatigue did continue. So, I know that in earlier sessions, individualized treatment plans were highlighted. And definitely when it comes to fatigue and pain in individuals with OI, an individualized treatment plan is very important. One observation is that medications or surgeries may provide benefit, and medical causes need to be evaluated. A single intervention is not likely to quickly fix long-lasting pain. It's also important to take pain seriously and address it when it does emerge. If surgery is not required, promoting physical conditioning is very important. Often one discipline is not fully able to evaluate all of the contributors to chronic pain and fatigue. So the approach is often multidisciplinary and rarely has a quick fix. Ideally, medications are used to help control pain, while underlying issues such as physical deconditioning are addressed. Great, so there's rarely a quick fix for chronic pain and fatigue. Opiates have historically been used to treat pain and sometimes chronic pain. One obvious use in OI is the use of opiates at the time of fracture or with surgery. In the current climate and with increased regulations, the use of opiates has become more challenging. I would say, there are lots of complications. I can speak to how things are in the state of Maryland, where now to prescribe opiates, we require patients to sign contracts and undergo drug screening for prescribing opiates on a chronic basis. So there are some known side effects to opiates in OI, to the use of opiates, and that pertain to OI. This includes opiate-related osteoporosis, where lower bone densities have been described in some individuals that have been on long-term opiates. There's also been a correlation with an increase in fracture risk for people who are on opiates, and that's possibly related to the association of fatigue, drowsiness, and possible falls. And we also know that opiates may worsen fatigue and also lead to GI side effects. A newer treatment using CBD or THC, there's not extensive experience in OI. We know that fatigue may be a side effect of these treatments. And when reviewing the literature, it seems that most of the evidence has been mostly anecdotal. We don't have information from an OI population or side effects in a large population. There's some animal studies that have been done and suggest slowing down of bone deposition. Theoretically, there can be an impact on bone density, but basically we just don't really know a lot about how these treatments impact individuals with OI. So for these reasons, I don't usually provide treatment with opiates or CBD in my patients with OI. So rather than trying to fix the issue quickly with medicines, we utilize a multidisciplinary approach. And in today's session, we have speakers who will share their experiences with OI from the medication standpoint, behavior psychology standpoint, and also physical therapy and physical conditioning standpoint. So while this is not a quick fix, the ultimate goal with treating chronic pain and fatigue in OI is to stop the vicious cycle of pain, physical deconditioning, fatigue, anxiety that leads to more pain, and the cycle just continues, and move towards improving coping strategies, physical conditioning, and to improve strength and endurance. So to summarize my takeaway points, pain and fatigue are common in OI. Pain and fatigue are often present together and may be comorbid or present in the same individual. and a multidisciplinary team approach focused on medical treatment, long-term physical conditioning, and coping strategies leads to improvement. So today we do have an excellent panel assembled, all of whom represent different aspects in a multidisciplinary approach to treating pain and fatigue. I'm going to turn things over to Dr. Goeller, who's an associate professor in pediatric and anesthesiology at the University of Nebraska Medical Center and has extensive experience working with children with OI. She attended medical school at Lake Erie College, completed her internship at Doctors Hospital in Columbus, Ohio, and has completed her fellowship in pediatric anesthesiology at Nationwide Children's Hospital in Columbus, Ohio. So I'm going to turn things over to you, Dr. Goeller.
I'm making sure I have the right screen shared.
Looks good.
Okay, excellent. Welcome everybody. I've been very excited to be part of this conference, and I have had the pleasure of meeting so many of you over the years, and I developed a deep and abiding love for all things OI. I've learned so many things from your children and from you, and this has led to me really being more aware of the deficits in acute pain management and the types of treatments that would be really beneficial nationwide and throughout the world for types of strategies that we've been able to employ at our OI Center of Excellence in Omaha, Nebraska. And therefore have a lot of different research projects that will come out to share our techniques and experiences with other centers. I'm always very impressed with how we can all put our heads together and say, this is the way that we've been able to do things and have great successes. And I find that the feedback from parents and children who have OI have been invaluable in being able to guide and continue to evolve our treatments so that we are addressing the different types of pain as well surrounding surgery, fractures, and also long-term so that we are constantly trying to do better. So today what I wanted to talk about is addressing the fact that a critical aspect of chronic pain is the optimal perioperative and acute pain management surrounding a fracture. So I'm going to give a brief overview of aspects of medical pain management and reiterating what Dr. Jain was talking about with the multidisciplinary approach as well as multimodal analgesia, which I'll cover. Just as OI is not all-encompassing to be the reason for all ailments or things that you experience, on top of that, attacking or addressing pain, acute or chronic, from a multidisciplinary approach requires what we like to say the 3 Ps. You have pharmacological treatment, psychological treatment, and physical therapy. And fortunately today we have all 3 being addressed. I find that when people are able to use all 3 of them and strategize, you have a synergistic outcome compared to hoping for just one medication or several medications to address what you're experiencing. So I will go over those different things in my acute presentation. Let's see here. So I want to discuss the pain considerations unique to patients with OI undergoing surgery, describe multimodal analgesia for patients with OI undergoing orthopedic procedures, and also address challenges navigating the needs with providers unfamiliar with OI. These are types of topics that I'm hearing constantly from families. So preoperative considerations, if you're having surgery or your child's having surgery, The type of surgery that you're having makes a difference to what strategy will be employed. If you have lower extremity surgery only, then you could use things like an epidural, or a peripheral nerve block works for upper and lower. Infrequently, upper extremity regional anesthesia, where you numb the limb, is employed because of risks associated with what's called compartment syndrome, where you want to be able to assess the nerve and the blood vessel perfusion status within a certain time frame after surgery. And so if you were to numb that whole arm, let's say for a forearm surgery, you may be numbing the area that would give you alerts on if something were needing to be addressed in a short period of time. So sometimes doing an upper extremity block where you block the signal using local anesthetic of the pain sensation going to the head, it'd be better to use a systemic approach, which is taking medications IV or orally in order to treat pain in an upper extremity. So the surgery type that you're going to undergo makes a difference to what strategy is employed. The physical exam makes a difference because while in our experience, people who have OI don't tend to have respiratory depression or sedation effects from a lot of the different medications that are sedating to people that don't have OI. If somebody experiences severe sleep apnea or has respiratory symptoms, ensuring that you time the medications appropriately so that they're not all administered at the same time is one of the critical components. And so assessing whether you have underlying sleep apnea, central or obstructive, and whether you need an oxygen requirement, or whether your respiratory function has started to decline based on the musculoskeletal structure, that's going to be a critical component. Anxiety plays a lot into whether you have a good or a bad experience perioperatively, and addressing anxieties associated with going to sleep, getting a port access or IV starts, especially in young children. I think that making sure you have a good experience associated with anxiety starts the process of knowing that you're going to have repeat procedures to ensure you have a good experience, especially for your child, because you don't want their anxiety ramped up really high from inadequate treatment of getting an IV or a port accessed. And I find that making sure that the child or patient or person who has OI has a lot of control over how you would go about that has really been beneficial for that. Prior medication needs, what you've used before, whether you have tolerance, what your previous dose was. I find that when patients go to emergency rooms or places where you're unfamiliar, they are not comfortable dosing opioids or muscle spasm medications the way that we do. So understanding what your needs are before surgery means that we can start at a good point knowing that you're having a surgical procedure. So cute. Okay. IV versus mask induction. I find a lot of patients don't really like a mask because of previous experiences, so that when we have an IV started ahead of time and allowing somebody to choose whether they do it that way for a pediatric patient has been very helpful, because if they know what to expect and we can treat it as such, it decreases anxiety significantly. We use special intubation precautions. Blood pressure monitoring is a big hot topic all the time. We have special OI settings, which means that it doesn't increase in pressure above what a neonate would experience. But we use very, very prudent blood pressure monitoring while under anesthesia, and then we don't measure before and after. But we've never had any issues, knock on wood. But at the same time, we're very, very prudent on that. Regional and neuraxial, we have found, has been very critical to the experience. Having bilateral femurs or both femurs rodded or re-rodded or just both legs, having an epidural for postoperative pain control has really changed the recovery and the anxiety-provoking experience for children and adults alike. Having a C-section or delivering a baby with an epidural or with a spinal, I think has a huge benefit over the risks of putting in a breathing tube if you have challenges with your mouth or your airway. So multimodal analgesia, in brief, is taking care of pain from the using different strategies, and from a medication standpoint, multimodal means you're going to address nerve pain, spasm pain, overall pain, and we're going to look at layering different types of strategies so that you can address the pain foundationally with a non-opioid type treatment like Tylenol and a non-steroidal anti-inflammatory like Toradol, ibuprofen and such, if you're able to take it. And then using things like an epidural or a regional block to block the pain going to the central nervous system until you kind of overcome the hump, which is usually the first 24 hours and sometimes 48. Ensuring that a muscle relaxant is treating the spasms that are associated with an acute fracture or surgery. And we find that even if you have an epidural and you're completely numb sensory-wise in the lower extremities, that having a muscle relaxant scheduled is still very critical, because the muscles need to be able to calm all the way down from having surgery. And you can see young children be kind of spasmed awake from a spasm that if it isn't adequately controlled. Opioids, there's a lot of different things we could talk about with opioids. I find that even patients who have never been exposed to one before, I feel very comfortable prescribing and administering reasonable doses according to what their needs are, and of course their past medical history and their airway. We found that historically combination products like having hydrocodone and chlorpheniramine maleate, which is Tusionex, has been well received in some communities because the antihistamine is helpful. And we also find that when we move out away from a combination product, so we can optimize the Tylenol and have oxycodone or use the hydrocodone acetaminophen version, everybody has their own medication that works best for them. We don't like to do to just use one specific opioid to treat the pain. And using patient-controlled analgesia has been very helpful, especially for like an upper extremity surgery, where then you don't need to wait for nursing to bring you the medication that you need overnight, and you have a drip going. And nurse-controlled analgesia for those that are not mature enough to use a button yet, like 2-3-year-olds, etc. Adjuncts are especially critical. We found that gabapentinoids like gabapentin or Lyrica have been especially critical with orthopedic surgery, because the nerve pain that's associated with having surgery, and even if you haven't had a surgery but you've had a fracture, can really be helpful in decreasing the total amount of opioid or muscle relaxant that you need by addressing the nerve pain specifically. And using it just at night or twice or 3 times a day, even just for a few days, has made a huge difference. There was a short period of time where we decided to take it out of our regimen, and we did see a difference in the amount of pain control that was able to be achieved. And so we use that as a foundational element of our pain protocol. Clonidine can be helpful. Dexmedetomidine has been very helpful for times when pretty big surgeries are done, and where we have used every single regimen and psychological and physical therapy treatments, and it's just ramped up so high that we will use a Precedex drip, and that has been very, very helpful for some of the really hard cases. So as you can see, utilizing all of the different layers of approaches to taking care of pain can really be critical to the experience. And one of the quotes that I'll give you from esteemed parents of the past is that historically for lower extremity surgery, when, let's say more than 10, 15 years ago, when epidurals weren't utilized because of fear of complications, there would be parents all gathering together. The OI community is really amazing at how you support each other, but parents would gather together and hold vigil for the first 24 to 48 hours because of how challenging it was to overcome the big acute phase. And so we are very big proponents of using regional and neuraxial, which is epidurals and nerve blocks for surgery. Other considerations after surgery is some patients will wake up and feel very anxious about where they're at and kind of waking up after surgery. And so we try to address that pretty quickly so that we don't have anxiety contribute to increases in pain. It's important to address that you get discomfort just from laying on an operating table or laying in bed during recovery, and being able to treat pain that's from the non-surgical sites is just as critical as treating the surgical pain. Continuing to address anxiety from all of the different approaches, and we have really, really good distraction and non-pharmacological treatments and approaches that we use too, and parents really come up with really great ways to address anxiety too. And then also the other critical pieces are the nausea, itching, and some medications make people not feel very good. And so you have to ensure that the whole experience doesn't, all aspects play into the other. If you have significant nausea or significant itching, or you're feeling really just off from the medications, we try to change things and address them. One of my favorite things I tell people about that I love about the OI community is I believe that you have intellect far beyond any typical population. And so one of my pet peeves is people talking to people that have OI as if they're younger than they are just because of their size. So we address the intellectual considerations. Ask your child and your patient what their needs are, and they know what they need, they know what they like, and let them make decisions, and that is a huge aspect. So the last thing I wanted to cover is navigating the needs of providers unfamiliar with OI. I also hear a lot of stories of going to urgent care and emergency rooms and all they're offering, because your child or you yourself is not screaming out in pain from an acute fracture or issue, that here's your Tylenol, we did an x-ray, you can go home. Educating emergency room providers and urgent care providers, as well as primary care providers, with information and literature is going to be critical for them understanding that this community needs to have their pain addressed appropriately. And that requires a multimodal approach. You need your diazepam or whichever muscle spasm medication is critical. And if they're not comfortable with it, they need to reach out to somebody who is comfortable. But taking your post-operative paperwork and taking printed out literature is very helpful. And the final piece is there's a lot of legislation, as Dr. Jain mentioned, about not providing opioid prescriptions that pharmacists in different states don't feel are necessary. We've even heard that in some states they have empowered our pharmacists to not provide opioids under the age of 6, which the Society for Pediatric Pain Medicine has been aggressively addressing since that has come out, because it doesn't make any sense to me that anybody thinks that somebody experiencing multiple fractures just because of their age being under 6, that they don't deserve to have opioid analgesics because populations in other areas may not be using them appropriately. So addressing that, how do we navigate those needs? By providing previous paperwork, and in Omaha we also have a pamphlet that we created for post-operative and post-fracture pain information for providers, which if any of you are wanting a copy of that, feel free to email me or Dr. Wallace or the OI Foundation, and we can mail you a copy. But providing them with the information they need because of their lack of familiarity is one way. And another is to say, I understand that it may seem that I'm asking for medications that don't seem appropriate for a child or for somebody like me, but this is standard of care for people who experience multiple fractures like we do. And so if people are uncomfortable, they really do need to contact others rather than just defaulting to Tylenol, which, to be honest with you, actually angers me a lot. I appreciate being able to participate today. So I'm going to turn it over.
Thank you so much.
Thank you, Dr. Goeller. Oh, I'm sorry. I was going to introduce Dr. Sova. He's an assistant professor of physical medicine at Johns Hopkins. And he's the co-director of the Adolescent and Adult Pain Connective Tissue Program at Kennedy Krieger. He completed his MD at Albert Einstein in New York, residency at Johns Hopkins in both physical medicine, and then a fellowship in pain management. So take it away, Dr. Sova.
So much. Good morning, everybody. Let me just. Good morning. Does everyone see my screen?
Looks good. Thank you.
Okay, thank you. First of all, I want to thank the OI Foundation for inviting me to take part in this forum. It is a true honor and privilege, and to be spending the morning for these next couple hours together with all of you. It's a real honor and privilege. So first, I want to disclose that I have no disclosures. And what I'm going to be doing today is discuss an overview of various different types of chronic pain. And we know that patients with OI have various causes of chronic pain. And I want to give just a brief overview of different types of chronic pain. Discuss how we assess pain when we have patients coming to our clinic. Gives a few clinical vignettes. And then at that point, we'll discuss some different medication classes to help treat different causes of chronic pain. So what are the different types of chronic pain that we have in general? So there are three basic types of chronic pain that are found. One of them is, the first one is called nociceptive type pain. And this is the most common pain. And when we think of nociceptive type pain, this is pain that's secondary to injury in the tissue. For example, you're in the kitchen, you're cooking, and you take a knife, you're trying to cut a tomato, and unfortunately, you nick and slice your finger, and there is now an injury in your skin, and you are feeling pain. This is a type of what's called nociceptive pain. This could also be such as injury in joints, secondary to arthritis. There's activation of what's called the small nerve fibers, which leads to communication and signals to our brain that our tissue is in pain and there's an injury taking place. That's nociceptive pain. The second type of pain, what's called neuropathic pain. This is a little bit less common, but still very common, and it's generated by the nervous system. It could either be secondary to the peripheral nerve system, that there's some sort of signal malfunction in the peripheral system. What is peripheral nervous system? That's anything, the nerves outside of the spinal cord or brain. Or it could be secondary to changes in the central nervous system, meaning the brain or the spinal cord. And again, since nothing is simple, there could also be mixed pain, which is both a combination of nociceptive type pain and neuropathic pain. So as I said, nociceptive pain is the most common type of pain. And when we're trying to do our assessment, we are trying to tease out what type of pain is the patient feeling. And what we find with nociceptive type pain, this pain is usually more localized with some radiation of pain around the area of injury, but it's not a large area of radiation. The way that they describe the pain is usually throbbing or an aching sensation. There's not this, what they describe as burning or numbness and tingling. And usually the pain will improve as the tissue heals. So if, going back to our original example, if you're in the kitchen and you unfortunately nick your finger and there's now a cut in your finger, we would anticipate as the skin heals, the tissue heals, the pain will improve as well. However, things like arthritis, which is more chronic, and more chronic changes might be there longer term. In nociceptive type pain, as opposed to neuropathic pain, which we'll discuss next, it's uncommon to have autonomic signs. And when I say autonomic signs, I'm referring to things such as temperature changes, a lot of swelling, which swelling could occur, but color changes. Even though these things can occur, it's less common. And it's also less common to have changes in sensation or motor strength because it's not affecting the nervous system. Neuropathic pain. Neuropathic pain is what we generally find is less localized type of pain. And the pain usually radiates in the distribution of a specific nerve. So if there's a nerve injury that took place, you will find that that pain will follow the distribution of that nerve. And often when you ask the patient to describe what does that pain feel like, usually these are the key words. They'll say burning, tingling, numbness, fire, thunderbolt. Often this type of pain is chronic in nature, and autonomic signs are more common here, such as temperature changes, color changes. And because it's affecting our nervous systems, the nerves, it would not be uncommon, and it would almost at times be expected to have changes in both sensation and or motor strength. So the question is, how do we assess pain? So there are a whole list of questions that we will address with the patient to tease out what is the cause of the pain. And the reason why this is so important and integral is because teasing out the cause of the pain will change how we manage the pain, because different medications will treat obviously different causes of pain. So the first thing we're going to ask is, where does the pain hurt? Is it more localized? Maybe that could lead us more down the nociceptive route. Or is it radiating in a large area behind the leg, going from the back down the leg? Maybe that's pointing us more towards the neuropathic route. When did the pain first start? Was there a precipitating event? Was there an injury that took place? Was there a fall? Since that time, is the pain better or worse? How about timing? Are there different periods of time when the pain is worse? Is it better in the morning when you first wake up? Or are you a little bit more achy in the morning and it's actually better with increased activities? Or do you find when there are certain movements, if you bend over, pain is worse? These are important questions, again, to tease out that will help us address the underlying cause of pain. It's important to ask about pain severity. You know, the common pain severity, we use the pain scale on 0 to 10. And we ask patients to say, what does your pain feel like right now on a scale of 0 to 10? And often we'll be asked, why is that important? How do you know what let's say I answer a 5 out of 10, how do you know what my 5 out of 10 means? And that's true. It's a very good point. I don't know what your 5 out of 10 means. But why it's so important is because pain is not just a point in time. It's something that's so crucial to be followed over a period of time. So when we originally assessed you and you said that your pain was a 5 out of 10, and then we see that patient back in follow-up and they said, we asked their pain severity and now they say 3 out of 10, we can assume that your 5 out of 10 has remained consistent and your 3 out of 10 has remained consistent. And we now know that there has been some improvement. So you're right, we can never compare anybody's pain 5 out of 10 to another person's 5 out of 10, but within that specific person, it allows us to be able to gauge whether your pain is improving or not. Next, it's important to have that pain description. As I said, is it more of this achiness, maybe more nociceptive, or is it more of a burning, tingling sensation, putting it more down the neuropathic route? What has helped your pain? What sort of medications have helped your pain in the past? What sort of movements have helped your pain? Or, more important, what has exacerbated your pain? What has caused your pain to be worse? And again, asking questions like numbness, tingling, and weakness will help us tease out the causes of the pain as well. So I want to start with some clinical vignettes. This is a patient with OI type 1 who presented to the clinic with multiple joint pains that are unfortunately limiting activities. This patient had a history of multiple fractures in childhood, which subsided in adolescence. Has undergone many orthopedic surgeries, including hip replacement, left knee replacement in the past. So when we have patients that describe pain like this in joints, also with a history of multiple orthopedic procedures, this type of history will have an increased risk of developing arthritis. And therefore, when we think of arthritic type of pain localized in joints, one of the things that we like to usually treat this type of pain with is an NSAID, a class of NSAID. And one of those medications in the NSAID anti-inflammatory class is meloxicam. So we started this patient on meloxicam, which dramatically improved the pain. We also started the patient on physical therapy to help improve the pain as well and to some physical strengthening. So that combination with physical therapy and with meloxicam, that patient's pain became much better. And what's the most important thing is it's integral to improve the pain. But what's also so important is not only pain, and what we try to tease out is function, allowing that patients to become more functional and improve their daily routine. It's one of the most important questions that I think we could ask is, what sort of activities do you want to get back to that's now being limited because of your pain? And pain is important, but we want to know, how is that pain impacting your daily routine? So fortunately, with this Mobic and meloxicam being started together with physical therapy, we were able to improve the function of this patient. So as I said, Mobic/meloxicam is in the NSAID, anti-inflammatory class. And it's commonly used to treat pain secondary to arthritis or inflammation, or quote unquote nociceptive type pain. Maximum dose is 15 milligrams daily. Usually we start at 7.5 milligrams daily and go up from there if needed. What we always like to tell our patients is always take with food and water, because some of the main side effects with NSAIDs are both, it could affect your GI system and it could affect your kidneys. So taking it with food and water could mitigate those potential side effects. And the other thing I like to say about anti-inflammatories, and what we like to tell our patients is, when you fall behind your pain, it's very hard to make it up. And what do I mean by that? Let's say, at any given day, you're going to be physically active. You're going to exert yourself physically. You're going to go to physical therapy. And after that physical therapy session, or after you take that walk, or et cetera, you're going to be feeling more pain because you exerted yourself. And then you take medication after that to sort of mitigate and decrease that pain. It's very hard at that point to sort of fight against that pain because you quote unquote have fallen behind the pain. So what we like to tell patients is, if you know you're going to go to physical therapy and you know it's going to be strenuous, an hour or two before physical therapy, try to take the pain, because now you have started your beating, you're staying ahead of the pain. And now likely the pain will be that much more improved. So clinical vignette number 2. This is a patient with OI type 1 and had first fracture of the leg at 1 year old. History is significant for many fractures, including left hip, shoulder, numerous finger fractures, and severe cervical, thoracic, and lumbar vertebral fractures. The onset of this patient's pain episodes began when the patient was in the late 30s after picking up large, heavy objects. So we talked about knowing description of pain, what sort of activities make the pain worse. Well, the patient told us it was worse after picking up large, heavy objects. Also, the patient told us that the pain was shooting down the right leg. Again, this is leading us down this sounds more like neuropathic. And given the fact that the patient had vertebral fractures in the past. So we did an MRI, and MRI showed a vertebral compression fracture and pinching on the L5 nerve root. So we saw that the cause of the pain, the likely cause of the pain was neuropathic pain, secondary to a herniated disc impinging on a nerve root that was coming out of the spinal cord. Unfortunately, this patient was debilitated by the pain and unable to, as we said before, function, unable to work for 2 years. So what we did was we started gabapentin and slowly titrated up, and pain slowly improved. So gabapentin Neurontin is in the quote unquote in the membrane stabilizer class of medications. It's recommended as one of the first-line medications for the treatment of neuropathic pain. But what's important to take note is that it doesn't take effect immediately. It really takes 4 to 6 weeks to see full effects, because how gabapentin works, it's sort of changing the signaling pattern in the pain nerves, and that takes time to sort of take full effect. So it's not going to be an immediate effect. Some of the common side effects include sleepiness and dizziness. And so why I mention the side effects here, it's important to note that because it is very common to have those side effects, and that's why we want to increase the dose slowly. Because sometimes if we increase it too quickly, patients will feel very fatigued and not be able to tolerate it. And then unfortunately, a medication that could potentially be beneficial will go on that do not use list forever, even though if we would have titrated up a little bit more slowly and allowed the person to acclimate to the medication and given more time for the patient to acclimate, this medication could have been very beneficial. So that's why we like to titrate it up very slowly. And usually the dose is up to 2,700 milligrams daily, which is split into 3 times a day dose. So 900, 900, 900 would be usually the maximum dose. But every case, as I is different. Clinical vignette number 3. This is a patient with OI type 1. And this patient reported that the pain was associated with increased activities. Patient had a history of scoliosis and vertebral fractures in the past. No orthopedic surgeries. Completed 1 year of Forteo therapy and received a dose of Reclast to maintain the effects of Forteo. However, unfortunately, there was pain that persisted sort of in the mid-back and associated with headaches and tension. So when we saw this patient, we noticed that there was a lot of muscle tightness. It seemed like the cause of the pain was secondary to some muscle tension. We started the patient on Flexeril as needed, together with some physical therapy, and there was improvement with the pain. Now the patient uses Flexeril sparingly if there are any periods of increased tension. So Flexeril is in the category of muscle relaxants. And as I mentioned, muscle relaxants is used to treat muscle spasms or tightness. And common side effects include headache, feeling tired, dizziness, dry mouth. And those are side effects that we have to be very careful, especially in the elderly, because it can cause confusion, delirium, and cognitive impairment. And usual dosing, again, dosing is, there is some room, but usual dosing is about 5 to 10 milligrams 3 times a day as needed. Clinical vignette number 4. This is a patient with OI type 3 who had generalized achiness all over the body, had a cluster of fractures during the 1 year span, and reported chronic bone pain and soreness. And because of that chronic bone pain, Pamidronate was started. And since starting Pamidronate, the fractures have been intermittent and has helped to provide an analgesic benefit. So it decreased the amount of time, the frequency to which the fractures were taking place, and also improved the pain. So this patient can feel when Pamidronate is losing effect. The pain worsens when the effects of bisphosphonates wear off, which is usually 4 to 5 months after infusion. And so this patient was originally getting Pamidronate every 4 months, but because by the time 4 months was reaching, they were really feeling a lot of pain and soreness. So we decreased it, so now it's every 3 months with improved pain symptoms. And as I mentioned before, it didn't only show improvement of pain symptoms, it also showed improvement of bone density. So in 2017, showed a 150% increase in whole body density. So Pamidronate, which is in the category of bisphosphonates slow down or prevent bone loss and help strengthen bones. So what do bisphosphonates do? They inhibit osteoclasts. So those are the types of cells which are responsible for breaking down and reabsorbing minerals such as calcium from our bone. And they also allow osteoblasts, which are the cells that help build bones, to function more effectively. So bisphosphonates have been shown to help improve bone-related pain. And finally, clinical vignette number 5. Patients with this was a patient with OI type 3 diagnosed at birth. History of more than 50 fractures in childhood alone, and 250 fractures before the age of 15. And this patient had a history of scoliosis. and complains of chronic pain in the upper back due to muscle tensions, secondary to the patient's scoliosis. So we find it's not uncommon to find that patients with scoliosis, depending on the degree of curvature, that they're going to have muscle tension in that area. So what we felt was, let's try trigger point injections. We implemented trigger point injections, and trigger point injections have helped to improve the pain and provide myofascial release. We also refer this patient to physical therapy for manual therapy and further myofascial release. So what are trigger points and what is myofascial pain? So myofascial pain is a fancy way of saying pain secondary to muscle or the fascia in the person's body. So it's pain secondary to the affected muscles or soft tissue. And myofascial pain is pain that arises secondary to what's called trigger points. And trigger points are these hyper-irritable points in a tight muscle, which is very painful to touch and can refer pain. So if somebody has trigger points and you touch it, they will feel a lot of pain, and sometimes they'll even feel a spasm sensation in that affected muscle because of that trigger point. So what are some of the causes of myofascial pain? What causes myofascial pain to occur? So these are some of the common causes, but there are other causes as well. One of them is injury, such as a muscle sprain or strain. That could cause some muscle tension. Maybe a poor posture, like for example, in the case discussion at hand, scoliosis can cause some muscle tightness. And anxiety. Anxiety causes increased sympathetic output within a person, which leads to muscle tension and fatigue. So these are all possible causes of some myofascial pain. So what do we do? So one of the treatment plans is for myofascial pain is trigger points, trigger point injections. So trigger point injections, what we do is this is usually completed in an outpatient office appointment. We try to localize those trigger points. And what is commonly done is we take a small needle and inject either a local anesthetic, or sometimes people use some normal saline. We inject into that trigger point injection a small amount of local anesthetic, which is used to break up that trigger point, break up those tight muscle bands. So together with the injection of the local anesthetic and or normal saline, together with the needle that's going within the muscle, the idea, the concept is let's break up that tight muscle band that's causing the pain. And usually this is not something that is a one and done. It's commonly repeated in order to break up that muscle tension, because if there's been muscle tension that's been built up over years, it's not going to be usually a one and done. But this is definitely something that could be beneficial, together with, like, for example, the patient that we had at the discussion, together with physical therapy to do some manual therapy and some myofascial release. This could be beneficial. So in summary, there are different types of pain, including nociceptive, which is that tissue injury, versus neuropathic, which is more of a nerve-related pain, and mixed, such as someone who develops a vertebral compression fracture, so a tissue injury, nociceptive, but that compression fracture is now impinging on a nerve, which develops neuropathic pain. So it's that mix, it's the nociceptive together with the neuropathic pain. And I hope I stressed the importance of doing an assessment of the underlying cause of pain, because it's so integral to tease out that underlying cause of pain, because there are various classes of medications depending on that cause of pain. So based on whatever pain that patient is feeling, that will lead us down a different route to help treat that pain. And then this is a summary of the different medications. Some of them we discussed, some of them we didn't. We didn't discuss. I just tried to give a brief overview and a whirlwind tour of chronic pain, but we discussed some of the analgesics. We discussed Movif. We didn't discuss antidepressants today. We discussed some membrane stabilizers such as gabapentin, muscle relaxants such as Flexeril. We didn't discuss topicals today. We discussed bisphosphonates, and we discussed trigger point injections. Thank you so much. It was a true honor and privilege to be joining this forum today.
Great. Well, thank you, Dr. Sova. So next up is Dr. Popenhagen. He's the lead for mental health services in the pain medicine program at Phoenix Children's Hospital. He received his doctoral degree at Minnesota School for Professional Psychology, completed his fellowship at St. Jude's in Memphis. So please take it away, Dr. Popenhagen.
All right, can everybody hear me okay?
Sounds good.
Okay. There we go. All right. Well, again, I'd like to thank everybody for having me be with you today. It is truly an honor to be here with you. So today I'm going to talk about the psychological treatment of pain. It's amazing how much the human brain can do to really manage pain. And so we're going to talk a lot about that today. Sadly, I don't have any disclosures to give to you today. And I'm going to try to really talk a lot about pain and mental health as a general overview. I'll talk about some very specific treatment approaches as we move along, going over the ones that I tend to use more commonly with some of my folks who have OI. And we'll talk about really treatment approaches over the lifespan. And then at the very end, we're going to touch a little bit on some sleep hygiene and see what we can do to help folks with sleep. All right, so people often ask me—
Dr. Popenhagen, I apologize.
Yes.
Speak a little bit louder into your microphone.
Okay. All right. Is this better?
Sounds a little bit better. I'm reading some of the comments.
Okay.
Thank you.
All right. How about this? Is this better?
That does sound a little better. Thank you.
Okay. Oops. All right. So people often ask me about pain and mental health and kind of what affects pain. Well, pretty much everything. So how you're hardwired, genetically, what's going on in your environment, your thoughts, everything that is around you, is part of you, really can affect your pain. So does that mean the pain is all in your head? Well, no. If you have migraines, of course, but other than that, no. The pain is where you say it is. It can be caused, like Dr. Sova said, in many, many different locations or in many different reasons, but the pain still affects you very deeply. So to discuss pain throughout the years, we'll start in infancy. Now, there's a lot of different strategies that you can use with an infant. In years past, folks used to think that kids don't feel pain. In actuality, there is some research out there showing that infants may feel more pain than adults do, simply because their nervous system isn't quite developed enough yet. And so they also don't have the coping strategies that adults have learned to use throughout the years. So things like sucking and feeding, so a pacifier or nursing, swaddling, kangaroo care, which is having skin-to-skin contact, oral sucrose, goes by the name of Sweeties. It can be a powder form that you dip the pacifier into. It can be really great for pain. Now, the trick with Sweeties is that you don't want to use that for anything except pain, because it will wear itself out and will become less effective over time. And once it becomes non-effective, it's always non-effective. And it does tend to wear out by the age of 1 year. Moving on to children, children can use some more advanced techniques. Things like distraction can be wonderful. For any of you who have kids, we all know that put our child in front of certain TV shows and you can do anything and they won't even notice. Relaxation, there's a whole lot of different relaxation skills. Talk about a deep breathing exercise here in a bit, but simply blowing on a pinwheel or blowing on bubbles. These things can be really quite helpful. But even other strategies as the kids get a little older, to use things like hypnosis and biofeedback, virtual reality, other techniques like this that we'll be getting to in a while. There are some really important strategies to remember when working with kids and teens. We all do this first one. We all do status checks and we all apologize. Why? Because it's what we've all been taught since we were little ourselves. But honestly, the frequent status checks and the apologizing actually tends to make pain worse. So what we really encourage parents to do with their children is to focus much more on those independent coping skills. What are those? Well, we'll talk about those here in a little bit, but really showing positivity and great use of your skills. I'm so glad you're breathing. Breathe with me. Let's go to the beach. Let's do the skills that we've been working on. These kind of things help put the child in a position where they feel like they're much more in control. And that feeling of control can have some amazing positive effects. Adolescents through adulthood and older adults can often use more of the similar techniques, much more advanced techniques. We do, of course, want to modify these to be age appropriate. For younger teens may have some different distractions than some of our folks who are a little more seasoned. So there's a list here of a lot of different things that I like to use. So focusing on psychology, right? What can we do to use the power of the brain to control pain? Now, many of you may hear of things or of a technique called CBT. A lot of you may have been referred for it, and sometimes I'm finding that folks who will do the referring don't know what it is. I've heard there's a CBT thing, I want you to go out and do that. Well, really what cognitive behavioral therapy is it's just a theory. It's an approach that most of us psychologists use. There are many others that other psychologists use. But basically what this technique does is helps you focus on changing your interpretation and your experience of the pain, and really helping you focus to think a little more differently about the pain and give you that sense of control. And so, for example, you may have a time where you're having a particularly bad day and everything's going wrong, everything's just, nothing seems to be working that day. Then you have, a time where you maybe stub a toe or you bang into something, not something severe enough to break a bone, but just a minor injury. Now that minor injury, because you're so upset, you may hop around and say a few colorful words. But that same injury on a day where you're feeling wonderful and you're having a good day and everything seems to be going right for a change, you may have that same injury and not notice the pain as much. But it's really important to focus on living your life in spite of the pain. Being alive is easy, but living, that's the hard part, and that's what a lot of cognitive behavioral therapy will help you with. ACT, or acceptance and commitment therapy, really tries to focus on pain as being part of normal existence, but how we try to control that, and instead of letting it just be a part of our world, that's what leads to the suffering. And so pain relief for the technique of ACT tends to be really much more of a wonderful side effect, but is really not the primary choice and the primary reason we're doing therapy. Family therapy. Well, nobody needs to tell any of you that OI really impacts the entire family. It is not just for the person or people in the family who have OI. And really focusing on some good family work can be really quite critical to helping the person with OI live a much better and much more valued life. Helping folks get out of that sick role that sometimes our families will put us into. Allowing the family to work together as a team and everyone understanding everyone else's position. Sometimes I'll work with siblings of folks who have EB, and the sibling is quite upset because they don't get as much attention. But helping that sibling then better understand how their family member with OI is getting through their life can really improve things, but also then helping the person with OI understand their sibling's position, and then the family, the parents, understanding how everyone can get along better. Now, I'll get a little bit more here into some specific techniques. And one thing I wanted to say before I get into these is that these techniques really help a lot with different kinds of pain. Not here to take away anyone's medication. In fact, these tend to work really well when combined with medications. But the nice thing with these techniques is there are no side effects. They tend to put you in control of the pain instead of the pain controlling you. Can work for a lot of different kinds of pain, from bone pain to soft tissue pain, centralized pain, pain like migraines, all kinds of other things, because we know that just like folks in the general population, folks with OI can have other conditions that cause pain, not just fractures. So relaxation, there's many, many different things, but basically these are things to take your mind off the pain. Telling stories, listening to music, doing your hobbies, these kind of things can be really wonderful. Now, if you look at the immunization literature in little kids, they find that relaxation exercises can be better than numbing creams. The other wonderful thing about relaxation exercises is that or distraction rather, is it tends to work even better than numbing creams because it's faster. All right, so the next thing I love to teach folks is diaphragmatic breathing. Now, when I talk to people about this, most folks have learned quote unquote deep breathing. And what they have learned is breathe in with your nose and out with your mouth, which is great for short-term things, but it doesn't tend to work so much for the chronic pain and pain that's acute but lasting for a longer period of time. So I won't go through all the steps with you just because being mindful of the time, but using these skills or these steps while doing the breathing can give you a lot more significant relief. Positive mental imagery. Well, that's just a fancy way for go to your happy place. But it tends to be a lot more than just daydreaming. I'd like you to picture a place that you'd love to be and where you can involve all of your 5 senses. So here, of course, is using the image of going to the beach, right? See the water, see the beach, see the palm trees, feel that warm sun. What do you hear? Do you hear the birds in the palm trees? Do you hear the waves? Do you smell the flowers? Do you smell the sea air? Maybe if you've gone out into the water in your imagination, maybe you can even taste that salt water. So really engaging all 5 of your senses. And the wonderful thing with that is it just tends to overload your thought processes. And it's a whole lot more fun than focusing on a broken bone. Clinical hypnosis is a technique that I'll often combine with the guided imagery. And what that is it's super focused attention. It's not mind control like the movies would love to have us believe, but it can offer some really amazing pain relief. Case in point, and this kind of addresses a question that somebody asked earlier about what can be done if some medications aren't working, this technique can work amazingly well. Case in point is a patient I had many years ago who had open chest surgery, meaning we cut right through his sternum to repair some issues with his ribs and sternum. We found out during surgery he was allergic to narcotics. This was the only thing other than Tylenol that he was allowed to have. And this took what he said his pain score was an 8. I thought for sure it had to be a 10. But by the time we were done, he was down to a 2. He used this technique all through his recovery and rehab, and he did really quite amazingly well. Biofeedback. Biofeedback is a really interesting tool that can be used, but basically all it boils down to is monitoring a bodily function. So whether it's heart rate or breathing rate or your skin, the conductivity of your skin, these things can provide immediate feedback via a picture or a light or a sound that can help you monitor your body and bring your relaxation down and help you feel much more comfortable. Mindfulness is a technique that helps take the focus and the value off of the pain. I think we could all agree that a fracture, we would consider that in a word, bad, right? Finding $100 on the ground, that's good. But what if we could take the value off of that? So that $100 bill has as much value as a plain piece of paper, or a broken bone has the same value as being touched with a feather. So what it helps you do is just not care so much. And it's amazing that this technique actually works, but I found it can be quite powerful for folks with various different forms of pain. It does tend to work better in older teens and adults. I do have limited luck with this with much younger kids, but sometimes they'll surprise me. Virtual reality is another form of a treatment that can be really helpful and is really quite exciting, and it's a newer form of treatment. And the neat thing with this is, as computer systems become more powerful and VR equipment becomes less expensive, I think as we move forward, we will continue to have some really amazing finds here. So this is kind of an up and coming thing that's just getting better and better. All right, so to talk a little bit about sleep, because one of the first things I've noticed when it comes to chronic pain and acute pain is that sleep tends to go out the window. So sleep hygiene, it's just helping you get better quality sleep. It doesn't mean you sleep dirty. So, but what about sleep? The number one thing that I have to tell the teens that I work with is that I'd like you to turn your all electronic devices off at least an hour before bed. For the teens, a lot of them, I know it feels like I'm asking them to cut off their arm, but it's amazing how much better sleep you get if you don't sleep with the phone on your chest or under your pillow. So if it's waking you up all night, you're not getting good quality sleep. And if you're not getting good quality sleep, you're not really allowing your body to rest and to heal in the way it needs to. Other things with sleep hygiene is to help get you to focus on a routine or a schedule every single night, even on weekends. I know this is a little hard, but keeping a schedule and a routine can really improve your body's sense of when it's time to go to bed and when it's time to wake up. The other big thing that I notice with teens, especially who love to spend a lot of time in their rooms, is that they'll often use their bedroom, use their bed as a sofa. And they'll use it for everything from homework to video games to talking to their friends, doing all these things. When they start to change from moving away from the bed as a sofa to the bed as a bed, then their sleep improves. Having some other comfortable seating in the room can be really helpful and really discourage using the bed as a sofa. Lots of other different things here, and I'll let you read some of these as we move forward. But one other last thing, if you're still having troubles with sleep and you're using all these techniques well, really then talk to one of your medical specialists about getting help from a sleep specialist. You may have a sleep disorder like obstructive sleep apnea or many other sleep disorders that could be treated and could really help you do much better. All right, and so thank you. I'll close here and move on from here.
Great, thank you, Dr. Popenhagen. So next up is Christopher Joseph. He's the director of the Physical Therapy Department at Kennedy Krieger Institute. He follows many children and adults with OI and is a member of the OI program at Kennedy Krieger and Hopkins. So please take it away, Chris.
Thank you, Dr. Jain. And I want to thank everybody and the OI Foundation for inviting me to this conference. It's an honor to participate in this as well. I'm going to share my screen here. Please let me know if there's issues with my screen share. So again, this is Dr. Jain, and I'm the Director of Physical Therapy at Kennedy Krieger, as well as the primary physical therapist in the OI clinic.
Dr. Joseph, excuse
yes.
me, can you go to display settings? And
is it backwards again?
Exactly.
Okay, we'll swap it.
Perfect, thank you.
Oh, no problem. So some of my objectives today is to talk about the impairments, chronic impairments that happen with pain and fatigue, OI in general with adolescents dealing with chronic fatigue and pain. Adults with OI, some of the natural history data that we discovered so far in our clinic, as well as some of the outcomes we use to assess some of the people with chronic fatigue and pain, and some of the PT treatments for this as well. So some of the common physical impairments impacting pain and fatigue with adults and adolescents with OI is recent fractures, right? We all know that they can lead to pain in people with osteogenesis imperfecta. Deformity, I've seen a number of things on the chat out there about, while I was watching the other presenters, about deformity can lead to pain, absolutely. Deformity leads to either tight or over-lengthened muscles, which can absolutely lead to musculoskeletal pain. Weakness, as we know, weakness in general can lead to pain because muscles are your shock absorbers in your bones, so weakness can also lead to pain. In general, people with OI have low muscle tone, which also, those muscles don't work as effectively, so they can also contribute to the pain. Joint laxity instabilities is a big one we see with people, with adults in our clinic, with their lax joints for either hypermobile mobility that can also lead to pain and fatigue, and weakness in ligaments as well. So some of the evidence about muscle weakness, I wanted to kind of touch on this with you guys today. The lower endonormal force production, this is shown in type 1 OI mice. So the muscles aren't as strong. They can't generate as much force, so they can't shock absorb as well with people with OI, which can also lead to pain as well as fatigue. They can fatigue out faster. The higher level of weakness response to injury. So an injury to an adult or a child with OI to the muscle can actually weaken the muscle faster, and also, again, lead to chronic fatigue and pain as well. Those muscles may take a longer time to recover as well. So, that's why it's important to understand this about adults and children with OI. And the presence of pain can be perceived as fracture. So, if you injure your muscle, it can severely become weaker and work less effectively. And this can be perceived as a fracture, so that you immobilize yourself more, which can also lead to more fatigue and chronic pain. And then the impaired collagen in the muscle also can impact, the muscle, make it less effective and with pain and fatigue. So some of the things we know about adolescents with OI, puberty, the fracture rate reduces, absolutely. Children, we're more concerned with the deformity and fracture, but with with adolescents, we become more, pain becomes more prevalent, and become more focused on pain and fatigue in those who do. So at this point, we know also in adolescents, those people with OI understand their abilities and limits more, and can help the therapist actually, treat their pain and understand their exercise. So muscle injury is greater than fracture in adolescence. So, it can feel like a fracture, which can lead to that Dr. Jain's demonstrated that pain and fatigue cycle. That's why it's important to keep those muscles strong. As well, it can be as debilitating as a fracture and a muscle injury in adolescents with OI. So I also put in here that we definitely want to balance protection with mobility. I mean, there's discussions out there all the time about braces versus not braces. So we want to have a balance between we want to rest the muscle enough so that it recovers, but we also don't want to brace it to the point where it leads to weakness and further fracture. So adults with OI, we know that osteoarthritis starts between the ages of 20 and 30, and Dr. Jain mentioned before and about the joint replacement and the stuff that can happen at this age. Start at this age if you need to. More pain in milder OI than severe, as we've seen. Dr. Jain reported also in some of his slides. And this is self-reported pain, actually. Also, people with adults that are walking report more pain than adults that are non-walking. That's something else we discovered in our clinic. And then immobility, we know that immobility leads to more pain. So again, we talked about this. Pain leads to sedentary behavior, and you have loss of range of motion, which leads to more pain and loss of function. So this is common. This can be common in adults with OI. So in adults with OI, we move from fracture prevention to treatment of pain and weakness. As osteoarthritis becomes more prevalent, we do look towards joint replacement. to decrease pain and increase mobility. So this can occur earlier. The downside of joint replacements is that they only last for about 20 years. So just have to be aware of that when you're making a decision for joint replacement. We also see significant leg length differences in adults with OI, which can lead to pain and muscle imbalance. You know, in the treatment of these leg length deficiencies, it's more about balance and control and comfort than it is about equaling out those leg lengths. So we're more concerned about making them feel comfortable. And then fracture can lead to more detrimental pain in adults with OI. So it can lead to bowing and changing in position of the bone and fracturing in the same location. So some of the natural history data we're collecting on patients learned so far with adults with OI in our clinic is that it begins in adolescence, of course. There's more reported pain with higher functioning adults with OI, and this is a significant factor in adults. We use the Energy Expenditure Index, the EEI, as a data indicator for pain in our clinic. Fatigue, what this EEI has shown us is that fatigue increases with age, and also that we've seen a great effect of an exercise improving actually fatigue in adults with OI. So some of the adults will come in with high fatigue levels even before they start some of the activities that we do, and then with the addition of exercise, their pain is decreased and their fatigue gets better. So some of the outcomes, again, I mentioned before already that we use the Energy Expenditure Index to give us an indication of fitness level as well as fatigue in adults with OI, as well as children. It's done on the 6-minute walk test, and there's an algorithm we use to predict, what their distance should be on the test for gender and age. It's a nice way for adults to be able to compare themselves to each other. We also use a 30-second walk test for those adults who cannot walk for 6 minutes, or actually children who cannot walk for 6 minutes as well. I know that with all the changes in COVID now, I added a slide in here about telehealth and some of the things we're looking at and when we assess people with using telehealth. So I wasn't sure if any questions would come up about that. So we use a 30-second sit-to-stand test, which can be a good indicator of strength in adults and children with OI. And we use that 30-second sit-to-stand test to compare them to themselves, as well as there's age-matched controls out for that. That test is how fast you can how many times you can sit to stand from a chair in 30 seconds. We also use the Borg rating scale of perceived exertion as a 0 to 10 scale that the adults and the children can tell us how tired they are using that scale before they start a test like this 30 seconds to stand, and then they can tell us how they feel when they're done, at least 2 trials, and that gives an idea of how the fatigue is impacting their function. And then the other test we use in the clinic for telehealth is the times up and down stairs. So we can compare this again to yourself, and it can see how fast you can walk up and down the stairs, one trial for a full flight. So we also use a quality of life survey for adults in the clinic for OI, the West Haven Yale multidimensional pain inventory. It was a measure that was developed to see how pain is impacting your experience in life. It's for adults, and it includes your significant others as well, so which is good. We need to know that, again, as Dr. Popenhagen had mentioned, that pain impacts the entire family as well. So we need to look at how pain impacts the entire family of life. So treatment, let's talk about a little bit about treatment for pain and fatigue for adults and children with OI. So I like to refer always to the OI Foundation guide that's listed in the website, and I have it here for you to go look through. Thank you again for the OI Foundation for helping us produce that. We really focus on joint stability and strength. Muscles are our shock absorbers, so it's really important to be able to maintain your strength to help help to get that shock absorption for your bone, right? We want to help to help reduce the chance of fracture in the future, as well as bowing. We know that bowing occurs naturally with people with OI, so keeping those muscles strong helps reduce that as well. Bracing, when we talk about bracing for people with OI, we really want to balance the degrees of freedom of movement with the muscle that's being taken away by that brace. So you really want to be aware of that when you're deciding what kind of brace. And at the clinic at Kennedy Krieger, we really look at reducing the amount of bracing as much as possible to keep those muscles strong and help, again, keep them as a shock absorber for your muscles. we talk about lever arms are really important for force, production. And with people with OI, we want to reduce those lever arms so that we don't injure the bone and cause fracture in the future, or even cause injuries and bowing to the bone. So being aware of those as well is really important. So pacing, this is something that's really important with adults with OI. Pacing is something that you have to be aware of when you're doing physical therapy treatment, as well as when you're doing physical activity as an adult and an adolescent or a child with OI. You want to do not fatigue that muscle to the point where it cannot prevent fracture and injury. So, this is the biggest thing we have when we talk about, PTs that don't treat adults with osteo or children with osteogenesis imperfecta. They have to be aware of pacing and not to over fatigue or overwork those muscles. So this is a really important thing to be aware of. And then manual therapy. I mean, we've had this talked about this over the years for a long time, how manual therapy like myofascial release and craniosacral therapy and, massage in general and contract relax therapy all helps to reduce muscle and pain and reduce increases length of muscles and makes them feel better, and it helps it fatigue as well. So, some of the treatments again for pain and fatigue is strengthening. We definitely want to do strengthening with adults with pain and fatigue. And as you can look here by our pictures as well as my opening picture, we love the pool at Kennedy Krieger. Pool therapy and aquatics is something we really strongly recommend, as well as being active in the pool with adults, children, and adolescents with OI. So. Strengthening, we do general strengthening with people. We want to distribute the weight along the length of the bone. We want to have proximal pressure, right? When you're lifting weights, you don't want that long lever arm to be forcing a lot of force along the bone. You want to work really on control and stability with, when strengthening with OI. We do want to avoid bridging. We know that causes torque on the bones that can lead to deformity. So that's something we also want to avoid. And we want to really focus on proper alignment and range of motion. Again, going down to aquatics, it reduces the gravity on the body as well. So it's helpful, for adults with OI. And it also, helps us, spread the weight along the full length of the bone and not at one focal point that can lead to fracture. So that's why we love working with using aquatics over at Kennedy Krieger as well. So some of the also things about exercise is that it has a positive effect on anxiety and depression, stress, PTSD, and it boosts its energy. There's some of the, Dr. Popenhagen talked a little bit about sleep behavior, for some of the adults that, have issues with chronic fatigue and, and trying to avoid to take those naps during the day, which really impacts your sleep cycle as well as your sleep in general. We recommend exercise for those adults. When you start feeling tired and want to take a nap, if you do something simple exercise, you can increase those endorphin levels, make yourself feel better, keep yourself awake a little longer, which also makes you a little tired at the end of the day and can lead to, some better sleep. So, when you feel like you're going to lay down and take a nap, that's the kind of time to get up and move and exercise if you can. And as Dr. Popenhagen talked about as well, we really pair cognitive behavioral therapy with physical therapy at Kennedy Krieger. So we want to work with the understand what strategies work for you to help, managing your pain. And we want to incorporate those strategies into your physical therapy program as well. So that's really helpful to reduce pain during the activities. I am a fast talker, so I got through this quickly, and I hope I'm trying to leave some time at the end for questions because I know we're a little behind. So, but here's my pearls for here today. Muscle are impacted by collagen, and they are your shock absorbers for the bone. So we definitely need to keep them stronger to reduce pain and improve fatigue. Pain and fatigue starts early and is reported higher in those with more mobility, and so pacing is important for adults, adolescents and children with, osteogenesis imperfecta. We definitely want to understand pacing and how to use pacing to be able to not over stress yourself and find that good rhythm for you. And pain is a part of OI. So learning good coping strategies, with the behavior psychologists is significantly important every day to impact the pain and reduce their level of function. So I went through relatively quickly. Here's my references. So I'm going to stop sharing.
Great. Well, thank you, Chris. So I'd like to invite all of the speakers to come back, share turn their cameras back on. We're going to move forward with our question and answer session. And as you know, it was a fairly lively chat, and we have several questions that have come through. So we have, I think we have permission to go maybe 5 minutes over, so we're going to extend the session to a little after 1. But first, why don't I take a question? One of the first questions that came through was asking, so if CBD may slow bone deposition, could that be positive for OI? I'll say that my answer to that question is I wish that I had more information. I wish that we did know more. Unfortunately, at this stage, it's not clear what potential long-term benefits or risks treatments with CBD may pose to individuals with OI, nor do we know what the impact is in bone. One point of caution I'll say is it's not uncommon that, I'm someone who wants to be very hopeful and optimistic, but I also think that being overly optimistic, it can be a danger. Let's proceed with caution. And I think we just need to know more and have more information. And that's the general, recommendation that I do give patients I see. Great. So I'm going to now ask Dr. Goeller a question. So in your presentation, you talked about some specific precautions with intubations. And a question came through asking about what precautions you do use for children with OI.
Great question. Within our practice, we do what's called inline stabilization because of the fragility of the neck bones and the fear of those that may have basilar invagination or just very close proximity in that area, that any extension of the neck could cause some damage. So we have our surgeon hold inline stabilization so that the neck remains neutral as we're managing the airway. And then frequently we'll use a video laryngoscope if we're placing an endotracheal tube, which is a special tool that has a light on it where we can look in the mouth without extending the neck. And then we have a video camera looking inside the airway, so it's not just you looking inside the airway yourself. And then we can very gently guide an endotracheal tube into the airway and protect it. When we're using a laryngeal mask airway, which is a soft airway that sits just behind the tongue but that doesn't go into the trachea and in the lungs, then we will continue to use inline stabilization and gently place that and seat it so that we can get good airway exchange and a seal. We find that to be very critical because if you were to hyperextend or even hyperflex or even twist, it's hard to know what level of torque could cause damage, and we don't even want to risk that. So that is our standard practice.
Great. Thanks, Dr. Goeller. So I'm going to move on to Dr. Popenhagen. Some questions have come up today, and I know in the adult session yesterday, there were questions with regard to PTSD, the management of PTSD and OI. A question came through today regarding the treatment of PTSD while in the hospital. Would you have any insight or recommendations for that setting?
Sure. Yeah, PTSD is definitely real for folks with chronic medical conditions of any kind, and especially, or OI is no different. Treatment in the hospital itself is a good place to start if you're already there. You can meet with one of the psychologists they're called consultation liaison psychologists. If you're in the hospital, you can just ask to speak to a psychologist. If your hospital has folks who are working on the floors, they're happy to help. But really, the important thing is to consider that, or I'm sorry, to continue that therapy after after you leave the hospital. Maybe it's with that same psychologist, but maybe not. But then to seek out someone in your local area, someone close to home, and someone who has an understanding of chronic illnesses, PTSD from medical conditions is a little different. I saw some things in the chat where folks were saying they talked with folks who had no idea what OI was or what it was like or anything like that. And it's important. And it's also important, if they don't know, to help educate them. You know, most of them really want to learn and really want to be there. And though I know it's not your job to educate us, helping them out can be a good start and really help with the relationship. Another type of psychologist that you might work with is one like me. I'm a pain psychologist. Technically, there's no certification for pain psychology. I'm certified as a health psychologist, but I've specialized in pain almost 20 years now. So we are few and far between, but finding someone who is a health psychologist would be someone to also help you out.
Great, thank you, Dr. Popenhagen. And kind of as a follow-up to that, I may ask Dr. Goeller, in an inpatient setting, if someone is having anxiety or symptoms that could be related to PTSD, are there any specific medications or medical interventions you would recommend for, say, shakiness or fast heart rates related to PTSD?
That's a good question. We try to use a prevention type strategy where we talk to, if it's in a pediatric patient, we talk to parents and try to avoid triggering words, triggering scenarios, address a lot of the anxiety provoking things surrounding a perioperative experience so that we don't cause it to manifest in a strong way, because there are always finessed ways to try to present the exact same material without using triggering words or adjusting the way that you would perform an anesthetic so that you're being cognizant of those things. One example would be those that may have experienced something difficult surrounding an inhalational induction where a mask, just looking at a mask triggers them to have some pretty severe anxiety, and that can manifest as some pretty sweaty and fast heart rate, etc. So we will annotate that they don't want anyone to show them a mask, they don't want a mask while they're awake, and that we will talk to them and say, we understand that you don't want a mask to be utilized, so we're going to avoid that. And then that way they can have some semblance of control around that. If we're already in the throes of a high anxiety situation, we find that if a waking up or emergence causes a significant anxiety from being in a situation that is unfamiliar, then we sometimes use Precedex or dexmedetomidine that can really kind of smoothen the wake up, and then have parental presence be a factor. Obviously, COVID has been a situation that's been difficult, but by having a parent standing there, and when they open their eyes, they're the first thing they see, that has been very helpful for helping in that situational anxiety. Besides that, medication-wise, sometimes the using diazepam for muscle relaxation can help with that. It doesn't always, but treating the underlying causes tends to be that exacerbate it tends to be our best strategy. Whether it's pain needs to be fine-tuned, or just getting them to their room after surgery and surrounding them with comforting and familiar things. I hope that helps.
Great, thank you, Dr. Goeller. I'm going to move on to a question for Dr. Sova. Some individuals are on pain medications for long periods of time, and you had mentioned gabapentin in your talk. Could you elaborate on the long-term risks or long-term benefits of being on gabapentin?
That's a great question. In general, we believe that gabapentin is safe to take long-term. However, as I mentioned, there are some side effects with gabapentin and might not improve over time, such as fatigue, sometimes dizziness. But we anticipate that if you have been tolerating well, that it is safe to continue. But sometimes we've seen that it could cause some disturbances in mood. With very severe cases, could cause depression and suicidal ideation. But like any medication, it's very important to keep a close eye on all these types of side effects. The one thing that I would stress is that it's important to keep in mind kidney function, that if there is an injury to your kidneys, that usually gabapentin goes out through the kidneys. So dose, depending upon what the injury is, it would have to be readjusted. And the final point I would make is that if pain has improved or for whatever reason gabapentin has been decided to be discontinued, that it shouldn't be cold turkey, we just take it off right away. It should be slowly titrated down over time and not just stop completely overnight. But that is a great question.
Great. And a sort of follow-up to that, have you seen muscle tension or tendinitis related to long-term use with gabapentin or Lyrica?
That's a good question. Personally, I have not experienced that with my patients. Not to say that that doesn't happen, but I'm not aware of gabapentin causing that, but it is possible, but I'm not aware.
Great, thank you, Dr. Sova. So I'm going to move on to Chris Joseph. So I know some comments and questions came through during your presentation. In my presentation, I talked about a vicious cycle of pain and fatigue, but a common experience, or an experience for some individuals with OI, is entering physical therapy, having an injury or pain starting or new pains emerging while in physical therapy. And this leading then to worse pain and worse fatigue. I know you had discussed or highlighted the concept of pacing, but would you have any insight on how to maximize the benefits of PT for individuals with OI?
So I think joint protection, pacing, and stability are the three important factors, I would say, for maximizing the PT for the adults with OI and adolescents and children actually with OI. So we want to make sure the person with OI understands they might be hypermobile and understand how to protect those joints when they're exercising, not doing ballistic or heavy exercises quickly. As well as working on stabilizing around the joints and not just using a single exercise to be able to strengthen one area, but also stabilize around the entire joint, as well as with pacing, you want to understand what the limitations are of your muscles and able to fatigue them, not to fatigue them, so that you don't continue to go on and exercise with a fatigue muscle and become injured later in future. So, and that's a little bit of practice with your PT, figuring out how much energy you can expend to be able to make those muscles, not overtired and be able to reach your limit, as well as, finding that spot for optimal functioning. Does that make sense? Sorry.
Great, thank you, Chris. We did have a couple of questions that did come in regarding bisphosphonates in adulthood. and which bisphosphonate may be best in adulthood. I'll have to say that while you know, the use of bisphosphonates is fairly common in OI, treatment is often, you know, it's important to individualize treatment. I can only sort of comment on my observations and you know, what I have seen and studied. For pain, you know, for individuals with OI, I have generally, bisphosphonates have been a potential treatment that I would recommend in the setting of chronic pain, especially bone pain, which is, you know, characteristically deep, achy, potentially present in many sites and outside of the joint. In my practice, I do typically give lower doses of pamidronate in adulthood. The reason, there are a couple of reasons. The first is an observation that potentially there may be, you know, and most of this is anecdotal, that pamidronate may lead to improvement, better improvement in chronic pain in our OI patients. A second reason is with the dosing of pamidronate, it has been, for some individuals that have pain in OI in adulthood, I will provide pamidronate, let's say at 6-month intervals, not for bone density, improving bone mineral density, but for addressing pain. We are able to move that up in our at our center to do it every 3 months, potentially at even smaller doses. So with pamidronate, there is some flexibility in the frequency of dosing, which for some individuals has proven to be beneficial when it comes to control. Great. So I'm going to move back to Dr. Goeller. And several questions came in regarding risks with opiates. So maybe I can go one by one. But do we know of, or what are the risks associated with long-term use of low-dose tramadol, which is a common medicine that individuals with OI may be started on?
Tramadol specifically also has SSRI properties, meaning like an antidepressant, selective serotonin reuptake inhibition. If you were to use that concurrently long-term with an antidepressant that is also an SSRI, then you can get serotonin syndrome. So that's something to be cognizant of. You can get like, there's a lot of different facets to serotonin syndrome, but if you're feeling ill and off, that would be on your radar as a differential when you're using two at the same time, and it should be avoided to prescribe both of those concurrently. Long-term tramadol as an opioid, along with other opioids, constipation when you're not using stool softeners is pretty significant, even on low dose chronic opioids. That effect never goes away. There are prescription medications to avert that, but we find that using 1 or 2 stool softeners like Miralax and Colace, and sometimes a prokinetic like Senna, have been helpful for those side effects when you do need to be on chronic low-dose opiates. Tolerance is one of the biggest ones because as you use it long-term, eventually you're not getting a lot of analgesia from it or pain relief, essentially low dose over time by if you don't continue maintaining the dose or slowly reducing it and eventually getting off if you don't need it, then a lot of times you're dependent enough that you will experience withdrawal effects if you stop using it and you need ever increasing doses to achieve any type of pain relief from it, which is why using other agents concurrently with it to treat pain is better than just using monotherapy or just opioids alone. Those are the biggest ones. the short-term side effects with acute use, like itching, nausea, vomiting, sedation, and those types of things, those tend to go away as you use them chronically. A lot of times people who overcome pain just have a very hard time coming off of opioids once they've used them for more than a few weeks sometimes, but long-term for years, it can be very, very difficult to come off of them long-term without a very, very careful program to reduce them, because it can be very taxing psychologically to come off of opioids when using them long-term. Does that answer the majority of the questions?
Yes, I think it does, Dr. Goeller. Great. So I'm going to move on to Dr. Sova. So sometimes pain, nociceptive pain, can be chronic, as you showed in your talk. Does that imply to you that there's further damage happening, or that there's a chronic injury that needs to be addressed?
That is a great question, excellent question, and a very common question. So I would say, unfortunately, there's no black and white answer. There are probably three possibilities when someone develops nociceptive type pain. For example, let's say a fracture, and has persistent pain. So one of them is perhaps the reason why person's still feeling pain is maybe, as you mentioned, actually, one of the possibilities is the pain, there is continued injury and progression of injury. Number two possibility is that there isn't continued injury, it's not getting worse, but the initial injury did not resolve and get better, and therefore the pain persists. And number three is the injury might have improved, but there is still persistent pain, because sometimes what ends up happening after an injury is that our pain signals in the nerves become hypersensitized, and they are still releasing signals that there is still pain taking place, even though there is no longer an injury there. So things that would help in such a scenario is that multidisciplinary approach, such as with physical therapy, behavioral psychology, to sort of quote unquote retrain the brain that there isn't an injury taking place right now, and to sort of bring down those pain signals. So there isn't one answer but those are different possibilities of why someone might still feel persistent, quote unquote, nociceptive type pain after an injury. Does that answer the question, Dr. Jain?
Yes, it does. Great. So in our last couple of minutes, I'm going to move to Dr. Popenhagen. In your presentation, you shared, one of the ways to try to help sleep or prevent sleep contributions to fatigue is to avoid daytime naps. There was a fair amount of discussion during your talk about any strategies to avoid daytime naps in the setting of chronic fatigue. Would you have any tips or pointers?
Sure. And I hear that a lot too. And I know healing takes an enormous amount of energy. And, with multiple fractures, it may not be possible to avoid a nap. Sometimes, though, folks will kind of get into the routine of taking a nap throughout the day. And yes, they may feel more refreshed, but then it ends up cutting into their time that they'll sleep in the evening. And so it can take a little bit of time to kind of play with when a good bedtime is and when a good wake time is. But beginning to eliminate those naps, unless you're ill or unless you have multiple fractures that you're healing from, or large fractures that you're healing from, it's hard at first. It's really hard at first. And remembering that, okay, I can do this. I'm gonna get better sleep at night. But if you find that you're taking a really long time to fall asleep, or you're waking up multiple times throughout the night and it's not pain related, that could be really part of the issue is those naps. And so going to bed earlier, though it's hard, or staying in bed longer, though that may be hard too with life. Seeing what you can do. And I mean, if you have to nap, then you have to nap. But if it's getting in the way of your nighttime sleep, then it's something to consider.
Great. Well, thank you, Popenhagen.
Yeah.
So we're now at the end of time for the session. So I want to thank all the speakers and the audience for a very lively chat. I hope that we were able to get through a majority of the questions that came in today. Of course, you know, please, if there are any other questions, please reach out to us, any of us, or the OI Foundation, who can help direct the questions to us. Great. So I'm going to turn things over to Michael.
Dr. Jain, I want to thank you all so much. To all of our esteemed panelists this morning and this afternoon, thank you so much for speaking on this very important topic. To all of our attendees who are still on, this session has been recorded. We will be posting it later to the OIF's website and then publicly online as well. And again, if you have any questions, feel free to reach out to us at bonelink@oif.org. And again, I want to make another final plug for our closing session today at 5:30 p.m. Eastern Time, where we're also going to announce the location of our 2022 National Conference. Very exciting. And thank you all so much, and we'll see you soon.